welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today I'm going to be talking about tranexamic acid for angiotensin converting enzyme inhibitor induced angioedema. So for our objectives today, we're going to describe the pathophysiology, presentation, and management of angioedema, analyze some of the previous literature related to the use of TXA and ACE inhibitor-induced angioedema, and then evaluate this recently published journal article regarding the use of TXA in this patient population. So I'll start off with some background. So we think about angioedema. This accounts for anywhere from 80,000 to 112,000 ED visits per year. And this is really defined as that transient subcutaneous or submucosal swelling, either in an isolated form, or this can be a component of anaphylaxis, like we'll talk about. This can either be histamine mediated or bradykinin mediated. And we'll talk about some of those differences here on the next slide. When we think about symptoms, this is really going to include that swelling of the face, neck, or throat, and depending on severity, how deep it goes, potentially hives, difficulty breathing, dizziness, or fainting. And this swelling is really going to be defined as non-pruritic and non-pitting, and so this is what's going to differentiate it between just our typical urticaria symptoms. So when we think about the two different types of angioedema, we really have our histamine-mediated and our bradykinin-mediated. So our histamine-mediated is what we're going to think about more that goes along with our anaphylaxis. So this is going to be triggered by either like an allergic reaction of certain medications, foods, potentially like animals or insects. And this is going to be diffuse and symmetric distribution and going to have more involvement of the eyes, lips, and really the entire face. And this is really going to have an onset that's really rapid over minutes and potentially severe in these patients. And it's going to be associated with other things like urticaria, flushing, pruritus, and in cases of severe anaphylaxis, other organs may be infected depending on how severe it is. And this is typically going to respond to things like epinephrine, antihistamine, or steroids, so really are kind of like first-line agents for anaphylaxis. Patients with histamine-mediated angioedema are really going to respond well to these. The other kind that we're going to focus on for kind of the rest of the presentation is our bradykinin-mediated angioedema. So this can be triggered by a variety of things. So our ACE inhibitors and ARBs, which we'll talk about, hereditary angioedema, acquired angioedema, and potentially even some minor trauma. Kind of the distribution of this is going to be focal and really kind of asymmetric, as you'll see. And this primarily is going to involve the tongue, lips, and then potentially the larynx, the more severe it is. But this really is going to be a lot slower onset, so more gradual, upwards of hours. And it's not going to present with our typical anaphylaxis symptoms of things like urticaria and pruritus, and it's not usually going to involve our other organ systems. And then of note, this is really going to be unresponsive to our traditional therapies, so epinephrine, antihistamine, and steroids aren't going to do much for this type of angioedema. So when we look at the pathophysiology of angioedema, this picture is kind of busy, but it kind of gives you an interpretation how this is really a spiral of a lot of different factors. So it kind of starts at the bottom where you have precalcineurin, which is transformed into kallikrein via factor 12 within our coagulation cascade. This kallikrein, this turns our high molecular weight kikinogen into our bradykinin, and it's this buildup of bradykinin that then causes our bradykinin-mediated angioedema. And then we kind of have this spiral where then in the endothelium, this bradykinin can release TPA, which can include the conversion of plasminogen into plasmin, which again activates our factor 12. And we just have this positive feedback loop, and we have this continued elevation of bradykinin, which can lead to this edema and angioedema. Specifically, when we think about ACE inhibitor-induced angioedema, it has an incidence of anywhere from 0.1 to 0.7%. But specifically, angioedema that's attributed to ACE inhibitors is anywhere from 20 to 40%. When we think about the mechanism for this, so we know our ACE inhibitors primarily inhibit that conversion of angiotensin 1 into angiotensin 2. But kind of one of their other mechanisms is it stops the breakdown of bradykinin. And so we get into its normally inactive metabolite. So we end up getting a buildup of this bradykinin like we kind of saw with our pathway before. When we think about some of the risk factors, female sex, older patients, and African American ethnicity have been shown to be at higher risk. Smokers are at a higher risk. patients who have concomitant DPP-4 inhibitors. So these can also inhibit that breakdown of bradykinin and put patients at an increased risk, and then any like prior history of angioedema. One thing to note, this really can occur at any point during treatment with an ACE inhibitor, so it's not something that occurs just within that first month of treatment. It can occur years later, no matter how long the patient's been on these. When we think about the general treatment of angioedema, one, we're going to start with kind of like our ABCs, so airway evaluation and management. Do patients have an indication for intubation based on really how severe their angioedema is, which we'll talk about a classification tool here in a minute. We're going to consider anaphylaxis and evaluate. So really trying to distinguish, is this histamine mediated or is it bradykinin mediated? And a lot of times this can be really hard to do up front. It's more looking at those risk factors and do patients have a risk factor for being one or the other? And really when it is unclear, we're going to trial those immediate therapies for histamine mediated. So our epinephrine, steroids, antihistamines, and really assess for that clinical improvement. If we see improvement, we're likely going to lean more towards our histamine mediated side. And then if we don't see an improvement, it's more going to be that bradykinin mediated angioedema. Obviously, we're going to treat the underlying cause, so holding any offending medications or substances that could have potentially caused this, and then really trying to assess severity and determine our patient disposition. So do they just need an observation period down in the ED for more of our mild cases, or do they need to be admitted to the ICU for patients who are potentially intubated, or patients, can they just go to the floor for maybe an overnight ops as well? So when we think about classification of symptoms, there was this paper published in the 90s called ISO classification that's typically been used for angioedema, and it's really just a proposed classification for monitoring the severity of this upper airway swelling. And so you can see there's stages 1 through 4. Stage 1 is really going to be your more mild, just patients might just have like a facial rash, facial edema, potentially some lip edema. But really stage 2 is where you're going to start to get that soft palate edema. So right at the top of our mouth may start to swell. Stage 3, you start to get that lingual edema. So that second picture there, this is going to be more of the tongue. And then stage 4, this is where you get that laryngeal edema, so down into the throat. They also talk about these general recommendations for general disposition, and then kind of is intubation indicated. Really your stage 1 and 2, these are going to be patients who can likely just go home, maybe just need a few hours of observation in the ED, potentially admission to like a floor unit, but intubation is usually not going to be indicated. Stage 3 and 4, these patients may require ICU admission and may or may not require intubation, of course, considering all other patient-specific factors. But in general, these patients are going to require a little bit higher level of care. So when we think about our management of bradykinin-mediated angioedema, our first 2 options here are going to kind of be our first-line agents. They're a little bit quicker to maintain in the ED and a little bit cheaper. Our last 4 are going to be our more specific agents. They're really more for our hereditary angioedema, but there is some studies and potential to use these in ACE inhibitor-induced. So tranexamic acid is going to be our first agent. This is what inhibits that conversion of plasminogen into plasmin and kind of helps with that feedback loop like we saw in our previous picture. Good things about this, it's a low-cost medication. Most people have comfortability with this that work in the ED, but really its data is limited to a lot of case reports before the study we're going to talk about today. Fresh frozen plasma and also an option. This does contain ACE inhibitor and our C1 esterase inhibitor, which allows for more metabolism of that bradykinin to potentially reduce any of our edema. So it's still reasonable to consider this for both ACE inhibitor induced and our hereditary angioedema. There's kind of one caveat for this. It does contain precalcinrin and factor 12. So there is that potential to worsen angioedema because you're then supplying those factors that kind of propagate that feedback loop. So then our last 4 agents, these are going to be things like our C1 esterase inhibitors, kallikrein inhibitors, and our bradykinin receptor antagonists. A lot of these are high-cost medications. They're going to be formulary restrictions. Hospitals may or may not even carry some of these agents. So really the utility is going to be institution-specific. And really these have mostly been studied in our hereditary angioedema. And the data in ACE inhibitor-induced is quite rare and not very promising for a lot of these. So they can be considered, but they're definitely going to be like last-line agents. This kind of brings us back to our pathophysiology. So you can just see where the different agents work. And tranexamic acid, they're working at the top, stopping that conversion of plasminogen to plasmin, which ultimately stops the activation of factor, and we can hopefully decrease that amount of bradykinin. So we look at some of our previous literature. So like we said, a lot of this is really just case reports or case series. So this first one was a case report of a 64-year-old female who presented with some tongue swelling and shortness of breath. She had a prescription for lisinopril for the past 2 years, so she was deemed to have ACE inhibitor-induced angioedema. She presented really stable. She had stable vitals, stable oxygen requirements. In the ED, she was given concomitant medications of diphenhydramine, famotidine, methylpred, epinephrine. So really are like first-line histamine-mediated agents. And then she was also given TXA at 1 gram times 1. They noted that her speech improved at 30 minutes. She had complete resolution of symptoms, and she was able to discharge from the ED at 2.5 hours. Kind of our next study was really a case series. So this had 11 patients. They were looking at adult patients with ACE inhibitor-induced angioedema, and you can see our median age was in the 60s, with over half being men and 100% African American, and you can see about a third of them had a history of angioedema. You can see concomitant medications, and our intervention was very similar to our case report. Most patients received those antihistamine agents and our steroids, with about a third receiving epinephrine. And you can see our average length of stay was about 1.2 days. They cited that no patients experienced any adverse events, and only 2 patients required intubation and treatment in the MICU. Looking at a few more studies, we have another case series that this one included 33 patients. So you can see baseline characteristics are relatively the same as our other studies. What's different with this one is their intervention. So you can see their TXA dose. They used anywhere from 500 milligrams up to 4 grams for that initial dose, with about half of the patients receiving that 1 gram, like our other studies. Also here, you can see that about 25% of our patients received oral TXA, which I think is interesting. Maybe they weren't as severe and were able to then take something orally. We can see about 80% of patients achieve significant improvement following TXA alone, with 40% of patients experiencing symptom control within that first hour. And they also reported no adverse events. Finally, there was one small retrospective study published with 16 patients with similar baseline characteristics as our case series and case reports. Similar concomitant medications, they all received TXA at 1 gram. And the only thing really different here is they did receive FFP for some of their patients. And they specifically looked at a primary outcome of rate of intubation and found that about 12.5% of patients required intubation post-TXA. But they did conclude, though, that 87% of patients had partial or complete response. And they also noted that there were no adverse events. But really, the effect of TXA for ACE inhibitor-induced angioedema is really limited to these small case reports, small retrospective studies with really no comparator groups and a lot of confounding variables. One being there's no comparator, and then no set criteria for our different agents that patients could receive that could potentially confound our results. So this brings us to our study that was recently published, Tranexamic acid for angiotensin converting enzyme inhibitor induced angioedema. This is a retrospective multicenter study. So the purpose of this study was to describe the effects of tranexamic acid on patient length of stay and other patient-centered outcomes in these patients with that ACE inhibitor-induced angioedema. In terms of methods, this is a multi-center retrospective cohort study. It was done within an integrated health system that had about 17 emergency departments, and they included all patients presenting to the ED with a diagnosis of ACE inhibitor-induced angioedema. And this was done over about a 3-year period from 2018 to 2021. In terms of exclusion criteria, they included patients 18 to 89 years of age who had a diagnosis of angioedema and then an active prescription for ACE inhibitor. So that's how they concluded that these patients likely had ACE inhibitor-induced angioedema as their cause. For exclusion, they excluded patients with only urticaria, as this is likely not angioedema, active prescription for an ARB, if they had a history of hereditary angioedema or C1 esterase deficiency, presumably pointing to another cause. And then they also just excluded anyone who they had a presumed angioedema from another cause, so potentially histamine-mediated or some other cause. And then any history of recurrent angioedema. When looking at our outcomes, so for primary outcome, they looked at patient length of stay. And then for secondary outcomes, they looked at ED disposition, need for intubation, any return to the ED within 7 days, and then some safety endpoints, death from any cause, and then thrombotic events within that 7-day time frame. In terms of statistics, for categorical data, they used a chi-squared or Fisher's exact test. Continuous data, they use a student's t-test or Mann-Whitney U test, all appropriate for this type of data. And then for statistical significance, they concluded that a p-value of less than 0.05 was then considered statistically significant. They did end up doing a subgroup analysis with a logistic regression patients who had specifically that stage 2, 3, or 4 angioedema to assess if that had any influence on their primary outcome. So when looking at enrollment, they assessed 330 patients for eligibility, with most of their patients being excluded due to it potentially being another etiology, followed by patients with a history of recurrent angioedema. You can see they had 73 patients in their tranexamic acid group and 189 patients in their control group. In terms of baseline characteristics, patients were in their upper to mid 50s, with just about half of our patients being male. When looking specifically at some of the past medical history, so smoking, which can be a risk factor, was relatively equal between groups, and then BMI greater than 30 was also equal between groups, as this could potentially have more severe presentation of their angioedema. In terms of previous ACE inhibitor-induced angioedema, you can see it was relatively equal between groups. And then in terms of risk factors for VTE and previous VTE, this was also relatively equal between group. So this was patients who had a recent surgery within 3 months, history of cancer, factor V Leiden, or the use of estrogen-containing medications. Also, you can see there was a little bit higher use of aspirin in our control group. This is really significant, mostly because NSAIDs can potentially be a cause of angioedema. So slightly higher in our control group, but not statistically significant between groups. We look at some other baseline characteristics. You can see almost all patients were on lisinopril, with about 90% in both groups. And then you can see duration of ACE inhibitor use. Most patients had been on this for longer than 12 months. So this wasn't patients who just started it and got angioedema right away. It can really be with any time frame. Kind of the biggest difference between groups and what led them to doing their subgroup analyses was this difference in angioedema isostage between groups. So you can see our control group, about 2/3 of patients were in that stage 1, so very mild cases. Whereas in our treatment group, you can see a majority of our patients are in that stage 3, even stage 2 category, correlating with more severity. You can also see there was a higher rate of ENT consultation in our treatment group, potentially pointing to worse severity in these patients, or potentially that was just easier for them to get an ENT consult. Being a larger academic medical center, they just had these on staff, and it was potentially maybe something they did for their patients. We look at medications administered, so you can see most patients receive things like our steroids, antihistamines, and even epinephrine. And then you can see even some patients receive that C1 esterase inhibitor, with about 17% of patients in that treatment group receiving this, which I thought was interesting and actually relatively high considering how expensive that medication is and kind of some of our formulary restrictions. So they did mention a majority of patients received an initial TXA dose of 1,000 milligrams, with that being a range of 1 to 2 grams. And they did note that 5 patients received an additional dose of TXA, ranging anywhere from 1 to 3 additional grams. When we look at our outcomes, so in terms of our primary outcome, length of stay, this was reported in hours. You can see it was almost double the amount of time in our treatment group at 40 hours compared to 21 hours in our control group. You can see in terms of secondary outcomes, rates of intubation. So while higher in our treatment group at 12% compared to only about 6% in our control group, this wasn't considered significant. You can see no patients experienced any clotting events. And then when looking at disposition from the emergency department, you can see there was a difference with most of our patients in the treatment group presenting to the ICU compared to in our control group. About 3/4 of patients were ultimately just discharged from the emergency department. Specifically, the authors then looked at a subgroup analysis to assess the difference of that length of stay for patients that specifically only were in ISO stage 2, 3, and 4, since we did see such a big difference between our treatment and our control group. So specifically, when looking at our treatment group, we see our confidence interval. So being that that doesn't cross 0, we can see that there's no difference. And with our p-value of 0.247, once we controlled for patients with that higher severity, they saw no difference in our treatment group with our length of stay. So really, the authors concluded that patients who received TXA had longer length of stay, higher rates of ICU admission, and a greater need for intubation. But specifically, when looking at those patients with stage 2, 3, or 4, there was no difference in any of these outcomes. And they also noted there was no difference in really our safety events in terms of clotting events or mortality. This kind of brings us to our critique of the study. So when thinking about some strengths and limitations, This really was the first multicenter study to evaluate TXA for ACE inhibitor-induced angioedema, and they really did have a large patient population with just over 200 patients. I thought they used appropriate inclusion and exclusion criteria, so trying to exclude patients that potentially had another risk factor, so like history of ACE inhibitor-induced angioedema, or that hereditary angioedema or C1 esterase inhibitor. And I thought they used appropriate secondary and safety endpoints, so looking at that need for intubation and potentially a risk of clotting event, while likely very low in this patient population, I still think it's something appropriate to assess. In terms of limitations, it was retrospected, and we did see that selection bias and really this idea of like confounding by indication. So patients who were more severe were then more likely to receive something like TXA because providers were trying to really throw anything they could at these patients to help them improve because our first line agents weren't doing that for them. I also think primary endpoint selection is potentially a limitation just because really length of stay can be influenced by a lot of factors. One, different providers may like patients to be observed for different amounts of time. Potentially, if they get busy doing something else, patients may end up just sitting longer than intended. Also, a lack of institutional protocol. So there was no criteria for which patients got which medications. So that exponentially increases our confounding variables. Also, medications administered by EMS was not able to be collected. So some of these patients may have received additional doses of some of our antihistamine meds or potentially epinephrine or steroids. And then the exact cause of angioedema is again not 100% certain with this retrospective study. So while they did have a prescription for an ACE inhibitor, we still can't conclude that it was 100% due to the ACE inhibitor. So it kind of brings me to my final thoughts and conclusions. So TXA, it's cheap, it's easily accessible in the ED. Providers, pharmacists, we all have comfortability with it, and it does seem to work for certain patients with our minimal adverse events. So I still think it's reasonable to recommend its use in this patient population, even if in some patients it might not work and we might not see a different outcomes. I think it's worth trying in these patients if we've tried our other agents and they're not working. Potentially development of an institutional protocol to just help streamline and have a consistent treatment for angioedema to then potentially go back and study and see if we saw any differences. Potentially, if we're going to want to look at this again, doing prospective trials are really needed to help determine the effectiveness of TXA for angioedema. Potentially with future trials, looking at things like clinical endpoints. So while I don't think we would really see a difference in mortality with this, maybe looking at that need for intubation as our primary endpoint and kind of preventing some of those more invasive procedures in these patients. Having consistent concomitant medications administered as best as possible, and then controlling for that severity of symptoms like the authors did with their subgroup analyses, but potentially doing this up front. And with that, I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.